Okay. Thank you for being here, the people that are here. Today is Thursday, January 29th. This is the Senate Finance Committee. I apologize that we're over an hour late, but we had a long floor session. So we're going to begin today with the briefing on Carelon and the Medicaid update. So I'm not sure who's coming to the table, but Carelon and the Medicaid update. I'm sorry, it's Deputy Secretary Perry Briskin and Alyssa Lord. Thank you.
Oh, you're right. I do need that. I'm sorry. Thank you. Thank you. Good afternoon, everyone. My name is Perry Briskin. I am the Deputy Secretary for Healthcare Finance and the Maryland Medicaid Director at the Maryland Department of Health. And I'm joined today by Deputy Secretary Alyssa Lord, Deputy Secretary for the Behavioral Health Administration, for this first briefing on an update on our Behavioral Health Administrative Services Organization, BASO, also known as Carelon. This is a little bit about what we will be going over today. So first, a little bit of background. This process started way back in January 2023 when we first issued the RFP for a new contract for our BASO. It was awarded on February 14th, 2024, and then we spent the remainder of 2024 transitioning from the old BASO to the new BASO, from Optum to Carelon. On January 1st, 2025, Carelon went live with their digital platforms and then with our call center, and then Carelon issued its first checks and payments to our providers on January 6th. There were a series of transition activities that were undertaken starting in early 2024. So establishing security controls, user scenario testing for Carelon, defining core business requirements, configuration, authorization of claims processing logic. And a lot of this required both partnership between Optum, the department, and Carelon as the new ASO. Once we went live, there was an ongoing refinement of authorization rules and claims and business logic, transition from the initial configuration to operational optimization, provider office hours, multiple provider calls and webinars, intensive coordination and oversight, making sure that Carelon was implementing the business requirements, and then many standing meetings between the department and Carelon, I would say multiple times a day, especially in the beginning. So it is no secret, especially to everyone in this room, that the system has experienced challenges over the last year. So since going live January 1st, 2025, there have been challenges faced by the BASO across 5 key areas, which we will go over. And I think one message, if I would like to leave you with any message, is that we are very close to reaching a steady state where we have overcome many of these challenges, overcome the backlog of claims that were given to us by Optum, and reaching a point where claims are getting paid on time, the business rules are in place, providers know how to submit their claims, and so we are reaching a new state with Carelon this year, and we are already seeing in the data that to be true. So most importantly, claims. Are providers able to bill and get paid? It's important to note that at Go Live, Carelon inherited 93,000 pending claims from Optum that were not paid and should have been paid. We have an average volume of 1.1 million claims per month, so just a significant volume that Carelon had to get up to speed on. It required targeted configuration, logic updates, automation where it made sense to result in faster processing. So all of these actions have resulted in a significant decrease in the inventory. So we have over 30-day inventory and under 30-day inventory. I want to say for over 30-day inventory, going from a peak of claims outstanding over 30 days from close to 140,000 claims in April to now, I believe this number is under 4,000 as of right now, but it was under 5,000 in December. So just significant progress. And a lot of those, some significantly are the hospital claims that took the longest to configure, and we are seeing great progress on the hospital front, which we will go into in a minute. This is just graphically our claims burn down, and so this is what we want that red to stay very small, if not minuscule. The red is over 30-day inventory, and then we want our overall inventory to reach total open inventory to reach somewhat of a steady state. But you can see over the course of calendar year 2025, we hit a high in March, and that I think was partially driven by claims that were still coming over to us from the prior vendor. But as you can see, we have reached a much more steady, reasonable state and made great progress over the course of the last 12 months. Timeliness, again, this is part and parcel, is also increasing. So the average turnaround time for most claims is now 9 days, and we process a total of 13.1 million behavioral health claims in 2025. So we will be the first to admit that there has been issues over the last 12 months with us working with the hospitals and processing them. But I am pleased to say that after last fall, and we frankly got called out by the hospitals, and maybe rightfully so, but we started holding regular meetings to make sure that the Maryland Department of Health was in those meetings with Carelon and the hospitals. There is important context here in that hospital claims are typically more complex than other provider claims, contain many different elements, require higher touch review. So in that claims backlog that Carelon was processing, the hospital claims were left farther to the end of the process. But we have been meeting regularly, and I personally have met with Hopkins, MedStar, and LifeBridge over the last few weeks, if not in the last week. And I can say they have all reported to me that things have gotten much better. And while there are a few sort of business configurations, business rule configurations, and billing rule configurations still to be done, we have made great progress. And so as a result of this intensive focus on the hospitals and their claims, we have reduced their entire inventory from 26,000 plus claims in April to under 8,000 claims in December. And then most importantly, that over 30-day claims inventory reduced from a peak of close to 14,000 claims in April to under 500 in December. We've also reduced the turnaround time on hospital claims specifically from 25 days to 11 days. We have also corrected denials. So we have reassessed areas where they were experiencing denials and reprocessed those claims, representing an additional, most recently, $7.4 million in paid claims that were previously denied. This is just another visual of hospital throughput and timeliness, and to show the progress over time that we hope to continue. Oh, this is the burn down. Sorry, I'm looking. This is the burn down rate of the outstanding claims, and then this is the throughput on the timeliness. We also, in the beginning, experienced challenges with the Carelon call center, high volume of calls, not enough call center workers. Through our oversight of Carelon, they added significant staff. It resulted in a reduction in call drop-off, and also more efficiently addressing the large volume of inquiries that they were getting. So Carelon receives on average 1,700 calls per month. And one of our key metrics is call abandonment rate. So we drastically reduce the call abandonment rate from a peak of 55% of people hopping off the call before reaching a call center representative to just 0.3% in December. This is to show the the rate of call abandonment increased 97%, and just the volume of calls that are received. And this is also showing the average speed and the speed of answer in how many seconds, and again, contributing to the lower call abandonment rate. This gets a little bit wonkier, but our BASO is tasked with auditing providers and auditing the system, and they have successfully conducted in calendar year 2025 231 audits across multiple provider types. And we expect that over the next year, we are going to double those audits, close to double, 425 audits we expect in calendar year 2026, with more comprehensive oversight and continued improvement in system performance and integrity. And I'll talk a little bit more about the data coming out of Carelon as well. So we know that there were some specialty providers that experienced unique challenges, but we have worked with Carelon to invest additional operational and technical resources to resolve these issues and implement long-term system enhancements to support accurate claims processes. So we understand that some providers experienced issues, but we have worked really hard with Carelon to fix the issues and communicate the changes to our provider community. And lastly, on reporting, and so the reporting capabilities and setting those up are ongoing, but we expect in the next month to have significant visibility into Carelon's data. And we are also trying to account for legacy claims found in Optum's platform, while Carelon data is accessed for current operations. So we are confident that in 2026 we will be more easily able to report what is happening in the Carelon system and more about our claims and our behavioral health payments. This is just a high-level overview of the year in data for Carelon. So 13.1 million claims processed, $3.2 billion in provider payments for behavioral health, 87% processed within 14 days, 90% of claims processed within 30 days. So these are all metrics that we will look to compare to 2026 and see how they compare, and hopefully continue to reach a steady state and see improvements. Lastly, just looking ahead, again, what we can expect in 2026. So we can expect additional enhancements to provider portal functionality, a refinement of authorization and service request logic for all providers, especially important for hospitals, national drug codes, that's what NDC stands for, continued refinement of how those national drug codes are handled and validated to support expedited claims processing. And we expect that configuration to be coming in the next month. And then implementing interoperability requirements in collaboration with Maryland Department of Health as a federal requirement, publishing electronic standard codes. And so we, again, feel like we are working confidently towards a steady state where claims and authorizations are processed timely and consistently, where we maintain reduced provider and participant wait times. Reporting is on a cadence that meets all contract requirements, and operations meeting contractual performance and compliance standards. And we will continue to work closely with Carelon and hold them accountable in the event that they do not meet their obligations under the contract. And with that, I will pause, and I'm happy to take any questions.
Thank you, Deputy Secretary. It's come a long way, because the last time I talked to you, we had, I think University of Maryland had 30 million in claims pending, and Hopkins had 25 million. So thank you for the work, and thank the people at Carelon. Do I have any other questions or comments? Senator Mounts?
I just want to follow up, and on a smaller scale, I can tell you the outrage and frustration for years and years, and to hear this is just wonderful. And I actually just texted some of my providers during this hearing just to make sure, because it's been such a problem. We've actually lost providers because of this situation, so it's great to hear. Thank you.
Lamb?
Yeah, thank you, Madam Chair. Just wanted to follow up. It sounds like a lot of progress is being made, which is good. I think that's very positive. Obviously, there were a lot of concerns with the prior ASO, and you referenced that as part of the presentation with Optum. Do we still have outstanding claims from the Optum period that are still out there, or has that all been resolved?
I think that has mostly been resolved. I don't know, Deputy Secretary Lord, do you?
Senator, happy to take the question for the record and get back to you if there are any outstanding claims that are tied to Optum. But it's our understanding that when you saw the burn down and that transition between those 93,000 that came down, that a majority, if not all of those claims have been reconciled, but we are happy to confirm.
Okay. Yeah, if you can get back to us, that would be helpful. And I know in the prior audit that took place while we were under the Optum period, there were estimated payments made to providers, which was over like $1 billion. The audit came back and said that almost a quarter of that had not been supported or recovered. Any update on that part of the audit?
Thank you for that question, Senator. I believe we also want to take that for the record and confirm. But yes, we did make advance payments to providers who are not getting paid properly to the system. They were not charged any interest on those payments, but we do want to recoup that money that we are owed. So,
sure. And if I may piggyback on that, so the process that ensued is that providers were given the opportunity to repay those estimated payments, and if not, they were then referred to the CCU. So we can certainly see what the collections rate is back from the CCU, but all that was turned over to our colleagues at the CCU.
Okay, so we're not quite sure right now of the $223 million that at least OLA found as potential estimated overpayments. How much of that has been recovered, I guess?
we want to get you the correct number, Senator.
Okay. And then last question, I guess, to follow up on the finding, one of the other findings in the prior audit. You know, they also, the auditors also found that there were over $20 million in liquidated damages that could have been assessed against Optum. There was a decision or a choice by the prior secretary, I guess, to not pursue the liquidated damages. It sounds like things with Carelon are much better, which is good. You referenced the fact that if there are issues that might come up, you may have other tools to utilize. You know, I guess what would be those other tools? Is liquidated damages still on the table? And what's the process for determining liquidated damages? Because there was a lot of potential liquidated damages that were just kind of left at the table for Optum. Mm-hmm.
So for the Carelon contract, we have what's called service level agreements in the contract that holds them to certain metrics. If they do not have the metric, if they do not meet those metrics, we have the authority to withhold payments to Carelon for their work. And we have exacted, we call them SLAs, service level agreement. We have exacted SLAs already on the Carelon contract, namely around call center time and other things. So we will continue to exact SLAs if they are not meeting the metrics that we're holding them to. As far as the $20 million for Optum, I think I may have to get back to you on that. I know there also is still active litigation as well.
Yes, so with that, we'll have to defer to our legal counsel for guidance as to how best to respond.
And then on the SLAs, were there SLAs in place for Optum as well? Or is that new for this contract with Carelon?
I think that's in all of the department's vendor contracts. That is not new. But if your question then is what SLAs did we exact on Optum, I think we would have to get back to you on that.
Okay. All right. Well, you have a lot to get back to then. So if you can get back to us,
we're taking good
that
notes.
would be helpful.
We're taking good notes.
Because it sounds like SLAs are not new, that this was also part of the Optum contract.
Yes, they are not new.
I'm assuming some of these provisions were executed as part of some of the deficiencies with Optum.
Yes.
it's good that these provisions are still here for Carillon. They seem to be doing much better, which is good, but
Yeah.
just want to understand the difference there.
I mean, I would wager, but we can also get back to you that we exacted SLAs, but just when you do an SLA doesn't mean there's actual change in the vendor. So we may have done a bunch of SLAs and nothing was changed, where Carillon, we give them SLAs and they actually make improvements in the system to phase out their SLA penalties.
Gotcha. Okay. Sorry, one more while I have you, because I was looking at slide 23 that said the majority of the claims were finished within 30 days at 91.2%. So, I guess I've heard from some in the provider community that there are certain cases that may have, thousands or hundreds of thousands of dollars that are outstanding claims, unpaid claims that are out there, and months have gone by without resolution. And so what's the process for resolving these issues with providers, and how can we streamline it or make it more effective?
I can start, and then Deputy Secretary Lord can weigh in. I think number one is letting us, the department, know. And I was going to say this to the other senator, that we need to be brought in. And so we have seen issues, and we've talked with Carillon a lot. When we are not brought in, things don't get resolved as quickly. So number one, reach out to me or Secretary Lord or our staff so we can be included in the conversation. Number two, every provider is unique and has unique issues. So sometimes we do find a legitimate glitch with the Carillon system, but other times it could be something the provider is doing and how they're submitting their claims that needs to be adjusted. And so every provider, when they have an issue, we need to sit down with them and get more information so we can correct it accordingly.
I think you've summarized it well. I mean, these are oftentimes one-on-one instances where Carillon meets directly with the provider and talks through whether it's an authorization or a billing issue. So again, please just refer providers to myself and Deputy Secretary Briskin, and we are happy to get involved.
Okay, so we can follow up with you directly if we have examples or concerns?
Yes,
Absolutely.
Okay.
And we want to hear that, because if there are systemic trends that aren't being addressed, we want to fix those.
Okay, thank you.
Thank you, Senator. Do you have any other questions? Well, that was much easier than I expected. Thank you. I think next you're going to present for the Maryland Department of Health.
Yes,
Second presentation. Thank you.
yes, yes. Getting all my pieces of paper. So this next presentation is going to be a Medicaid update, partially on our finances, our budget, as well as HR 1, otherwise known as the One Big Beautiful Bill Act, and OBA. So this is the agenda for today, and a lot of what is in this deck is in response to questions I have heard from folks here about what is going on with our Medicaid costs. Why is Medicaid so expensive? And so I wanted to include a little bit of that up front, and then also go into OBA impacts, which will be a significant change for the program. So these are just some highlights from the governor's allowance that was released just last week. So I think the top line is that there was flat funding for Medicaid. There were no cuts to benefits. There were no cuts to providers, which is frankly remarkable when you look at Medicaid programs in other states and what they are having to do to balance their budgets. The governor's budget also, the governor's allowance also provided funding for OBA. And so I just want to highlight, it was $1 million for Maryland Department of Health staff in fiscal year 27, as well as $2.6 million across Maryland Department of Health and MHBE for communications work. So this administration is investing to implement HR 1 in a way that will keep people covered. DBM has also earmarked $2.5 million for a dedicated purpose account to support OBA implementation across MHBE, MDH, DHS, and Maryland benefits. Outside of OBA, it also included almost $4 million for LTSS Maryland. It provided $882,000 for primary care quality IT infrastructure, and $15 million from the Cigarette Restitution Fund, and an additional 8.4 million general fund resources for Medicaid somatic services, 1 million general fund from the Community Health Resource Commission Fund to Medicaid, and then a 1.5 cost of living adjustment for state merit employees. And a salary equity adjustment has also been made. So this is just our overall comparing our fiscal year 26 to our fiscal year 27. And so while the total increased by 1.5 billion, the state portion was only by 227 million due to the federal match. I think something else I do want to emphasize about Medicaid is that 96% of our budget is spent on services for the people that are our members. So we only spend 4% on admin. That is drastically more efficient than, say, most commercial plans, which only spend 80 to 85% on their services. So we are by far your most efficient coverage program. So next, I want to give a little bit of a Medicaid overview. And the reason we put together, I'm calling it a Medicaid 101, is Medicaid is one of your largest items in the state budget. The people in this room make decisions that impact this budget. Medicaid states have tremendous flexibility to shape how the program operates, and it impacts a broad swath of Marylanders throughout the state. So the actions that you all take can impact care, costs, access, federal compliance, and also open Pandora's box to other things that are hard to close later. So just a better understanding of the overall system can help you make the best decisions and evaluate the proposals that are coming to you. So I hope this can be helpful. First of all, who are your Maryland Medicaid members? They're 1.5, almost 1.5 million individuals across the state. We cover 1 in 2 children in Maryland, 40% of all births, and a significant amount of people living with disabilities. We are also an economic engine for the state. Providers receive $17 billion in Medicaid payments. That includes both Medicaid and DDA payments to 130,000 total enrolled providers. We cover 57 hospitals, 221 nursing facilities. For nursing facilities, we are 80% of the nursing facilities facility payments. So we are your long-term care provider as well. 28 FQHCs, over 6,000 behavioral health providers, over 12,000 primary care providers. And then, of course, our Healthy Smiles program, over 3,000 dentists. This shows historical spending by delivery system. So we have about 43% through our MCOs, where about 85% of our members sit. We have other fee-for-service. We have home and community-based services, which includes DDA. We have behavioral health, and we have dental. But just shows sort of the breakdown of how things are broken out. And also you can see where there have been, as a percentage of the total budget, increases. If you look at behavioral health, you look at HCBS, you can see those changes. We also want to emphasize that a small number of members drive nearly 50% of the total spend. So that's our most expensive, our long-term care. So that's often our dual eligibles, our older adults who are enrolled in both Medicare and Medicaid, our members who are disabled. So you can see that children, as we say, are relatively cheap. They make up a large portion of our enrollment, but they don't cost very much. I do want to highlight that there are required and optional services that every Medicaid program in the country has. So there on the left side are required services. And then on the right side are optional services that Maryland has chosen over the years to fund. Fund because it's the right thing to do, but also fund that if you don't fund certain things, people end up in the ED, or they end up sicker, or they end up taking up other services. But it is important to note that optional services cost about $7 billion a year, almost 40% of total costs. It's also important to note that in recent years, provider rates have increased and new services have been added, also driving up costs. So you have things like 12 months postpartum, adult dental, biomarker testing, healthy babies, gender-affirming care. And then you also have fairly recent increases in provider rate changes. So calling out behavioral health, they have received for the last 5 fiscal years increases from 3.25% to 8% in increased rates, also increased rates for LTSS and dental, and E&M rates, evaluation and management rates. Hospital rates have also increased. This is through HSCRC and our all-state payer model. And just to note that when hospital rates increase, we have to incorporate that into our managed care rates that we give to into our hospitals. But we work closely with HSCRC. And these are required versus optional eligibility groups. So similar to required versus optional services, there's a set of people the federal government requires us to cover, and then there are optional groups that we also choose to cover as a state. These optional groups, if you took away the optional group, they may fall into some of the required groups, but if you took the optional groups away that would not fall under any other category, that is about $4.5 billion the state chooses to spend on optional coverage groups. This shows what the income limits are for eligibility in the various programs. So we cover children up to 320% of the federal poverty level. We cover pregnant women up to 264% of the federal poverty level. And then we cover most childless adults up to 138%. And to put it into context, those are the rates at the 100% poverty level. For a family of 4 at 138%, those are individuals making $44,000 a year or less. These are these are our lowest income residents who would qualify for Medicaid for Medicaid as an adult. And then children, we are a little more generous, and then beyond 322 for kids, or beyond 138 FPL for adults, that is where they can go to the marketplace and get tax credits. So just if we think about how do we manage costs in Medicaid, there are really 4 areas where we can do that. You can look at benefits, you can look at rates, you can look at eligibility, or you can look at additional financing mechanisms like supplemental payments. So when we're looking at how do we control costs, we typically look at these 4 areas. So I do want to flag, just because you can't avoid it, recent cost drivers of Medicaid. It's important to put into context, healthcare costs are on the rise nationwide. So we have drastically, as a country, increased health spending over recent decades. One thing I would like to flag is the Medicaid cost growth has been far, far less than commercial or Medicare insurance growth. So we are growing at a slower rate to just further show how effective the program is at both covering our highest need individuals while keeping costs down. For Maryland, the spending per Medicaid enrollee is on national average and lower than many of our neighboring states. It is also important to note that our costs have gone up because our state share has gone up. As a result of the COVID pandemic, the federal government increased the federal share in many areas of the program, and those flexibilities and additional funding have now sunsetted. In sum, these are our top recent cost drivers: pharmacy, inpatient utilization, higher acuity population following the public health emergency, new benefits, higher rates, and behavioral health utilization. And then this is all against the backdrop of our federal share decreasing and our state share increasing. And then just to highlight our Health Choice program. So our Health Choice is our network of 9 managed care that serves 85% of our population. These MCOs coordinate care. They get paid a per member, per month fee, so a capitated rate, and bear the financial risk of managing those individuals. From 2025 to 2026, we increased MCO rates by 10.7%. That is significant and not normal. Even with that rate increase, we put a profit cap on our managed care organizations of 1.3%. Even with that dramatic increase in rates of 10.7%, the 1.3%, most of our providers reported losing money in 2025. And we think that is really a result of just higher healthcare costs across the board, higher utilization, all of those cost drivers I displayed on the earlier slide. So we have a 1.3% average profit cap across all 9 MCOs, and the majority of our MCOs reported losing money, some worse than others. And so now I'll switch gears to talking about the impacts of OBA on our Maryland Medicaid program. So most importantly for you all today, I want to talk about the eligibility provisions that are coming. So on October 1st, 2026, there are changes to our immigrant eligibility. We estimate about 15,000 non-citizens may lose coverage because their immigrant status categories will make them no longer eligible for Medicaid. This does not apply to children. This does not apply to pregnant mothers. This does not impact healthy babies. Starting January 1st, 2027, non-disabled adults, what we call the Affordable Care Act adults, will be required to report that they're either working in school or have a medical exemption as a condition of their Medicaid eligibility. We estimate that about 115,000 non-disabled adults could lose coverage. And that is not because they are not eligible, but because they cannot get through the additional reporting and application requirements. Also starting January 1st, 2027, for the same group of non-disabled adults, they will have to go through Medicaid redeterminations every 6 months instead of every 12 months. We know when people have to go through redeterminations, that is when they churn out, they lose coverage despite their eligibility. And so between the work requirements and the more frequent redeterminations, that's what we expect to see the most coverage loss. There's also a shortened period of Medicaid retroactive coverage that is coming for this group, so going from 3 months to 1 month. Those are just a few. These are the other Medicaid OBA provisions. So you have impacts to Planned Parenthood, impacts to Medicaid financing, and then some other very weedy, wonky items. In total, with all provisions implemented, the state could lose up to $2.7 billion in federal funding. We know that no state in the country can make up for all the federal funds being lost, but it's good to have this perspective of what we are trying to maintain. The majority of this $2.7 billion is split between the coverage of those ACA individuals, keeping those eligible individuals covered, as well as state-directed payment and provider tax funding mechanisms that the state uses to fund its Medicaid program. This is to give a visual of when we expect to see the changes. So the majority of the coverage loss we don't expect will happen until mid-year 2027. That's when the 6-month redeterminations go into effect, work requirements pick up speed, and so we expect middle of 2027 to start seeing the impact. And these are some of the longer-term impacts of OBA. I do want to emphasize what we are doing to implement it. So we're focusing on staff, communication, and system changes, and that is where the governor's allowance will be very helpful. I think we are taking a cross-government approach, working in close partnership with Department of Labor, with our Department of Human Services colleagues, Department of Education, to make sure we are pulling as much data and making these processes as automated as possible, and using this as an opportunity to improve the Medicaid eligibility system overall. So in sum, these are our Maryland Medicaid priorities for 2026. Number 1, implement OBA and focus on protecting coverage for eligible Marylanders. Execute and plan for the AHEAD model, which is something we are already doing and starting to do in partnership with HSCRC. I'm happy to talk about this, but we are also very, very focused on fixing our home and community-based service disability waiver eligibility processes, making sure that that works for people and providers, because we know, and you have all heard from your constituents, that process is not working as it should right now. Continue to strengthen the BASO, which I just talked about, continue to improve Carelon payments and processes and reach a steady state, and continuing to push our health choice managed care plans to drive quality and drive savings. And with that, I'm happy to take any questions.
Thank you, Carrie. I was a little bit shocked on the page where you said Medicaid covers 1 and 2 children in Maryland.
That's correct.
That's a much bigger number than I thought. We have, what, 6 million people in Maryland? And 1.5 million are on Medicaid. And correct me if I'm wrong, with the new AHEAD model, when the federal government sets the Medicare rate, it also will be the Medicaid rate, correct?
Yes, and I
For the
think
hospitals.
that's what we have to make sure, negotiate and figure that out with HSCRC. But yes, that is the intention, and that's currently what we have now, is that the Medicaid rate is the Medicare rate.
So when we talked about cost shifting, that's where we need to have the commercial plans probably have an increase to make up, excuse me, that difference.
I would defer to my to other folks managing ahead, but yes, I mean, I think the model affords the Medicaid program in Maryland to have greater access than in other states, because in other states, Medicaid rates are much, much lower for hospitals, and so it reduces the incentive for those hospitals to care for Medicaid patients. So right now, we have great access, and we would like to maintain that.
The other question I have is I heard from folks that manage and own nursing homes. They feel like the approval for patients to move into a nursing home is very slow. Is that anything being done to improve that process?
Yeah, so we do approval to go into a nursing home. That's in partnership with our Department of Human Services colleagues, and we are always working to make that process better. So we know that that is an issue, and I can follow up with you on more details on what we're doing for that.
Does the patient stay in the hospital until their Medicare is approved for the nursing home? Is that what happens? Or Medicaid, I mean, is it? Do they,
I don't believe so, but I would like to get back to you on that specific
I
process.
appreciate it. Thank you. Senator Ellis, you have questions?
Yes, ma'am. Sure. Thank you so much. Thank you, Madam Deputy Secretary, for your briefing. I have a question on the spending per Medicaid employee, page 20 of your presentation. According to the chart, we're right in the middle nationwide spending per Medicaid enrollee. So we are at approximately $1,000 per month per enrollee, Maryland. Is that a good interpretation of your graph?
I believe so, yes.
Yeah, okay. And so we look at neighboring jurisdictions like Washington, D.C., they're at $1,400. I think they are the highest spending per employee, enrollee, around $1,400. Correct?
Correct.
Okay. So why would Maryland be, or I'll say this, why would the District of Columbia be 40% higher spending per enrollee versus Maryland? I mean, what makes up the difference between what is spent on enrollees in Maryland versus our very close neighbor in Washington, D.C.?
Thank you, Senator, for that question. And it's a very good one. I can take a few guesses because I don't know DC's Medicaid program as well as Maryland. It could be a variety of factors. It could be that they're more generous in who they cover. If you're undocumented, DC may offer benefits not just for pregnant mothers, as we do, but for other undocumented individuals. They could pay higher provider rates. They could have more flexible utilization management, so allow more costs, more utilization. So sort of all of those cost drivers I brought up, DC could be flexing on any one of those. My guess is it's the first one, that they provide more coverage to more individuals that may not otherwise be eligible for Medicaid. But we can certainly take a closer look at that and get you some reasons of why our neighbors are spending more than we are.
Yeah. So, yeah, thank you for that. So, the spending per enrollee, that amount, what percentage would you say goes to providers of services versus, say, medications and stuff like that?
I would have to get back to you on that. I think our pharmacy spend is significant, and I don't have those numbers off the top of my head, but we are spending a lot on pharmacy. I think the majority is going to our providers, but a significant, I want to say 3 to 4 billion is pharmacy.
Yeah, because I'm trying to understand if our, say, providers are not being reimbursed as much as, say, providers in Washington, D.C., that might be a disincentive for them to be providers in Maryland.
Yeah.
And we have issues like ER wait times, that's like the worst of the nation. And in my district in Charles County, we have a tremendous provider shortage. And so part of the issue might be the rural lower reimbursements for rural providers. But also, maybe just overall, those large percentage of the population that's on Medicaid, like up to what, almost 50% are children and stuff like that. The providers are just getting paid so much less. So why get paid? Why they do as much work and get paid less, like 40% less in Maryland? Why not just concentrate in other areas? I'm concerned about the connection. I'm not sure if I can connect those. Is that fair to connect that?
I think it's very fair. We actually put out a JCR that I can make sure we send to you that compares
I'm sorry,
our
JCR, what's
Oh,
JCR?
I'm sorry. A Joint Commission report. It's the reports that we give to the legislature on our program. And in one of our recent reports, we do compare our rates to other states in the region. So really put as a percentage of Medicare what Maryland Medicaid is spending. I would wager on our provider rates, we're actually higher than most other states. So that is, I don't know if it could be provider rates. I could be wrong. I want to check, but I want to send you the data. And one of the reasons I believe we are generally higher provider rates is because we're already paying higher for hospitals as a result of the model. And my theory is that it just sort of lifts all boats for the other provider rates. But I can certainly send you that table so you can see directly how our providers are paid.
Sure, thank you. And I wouldn't really compare nationwide. So at the bottom of the chart, we have like South Carolina, Florida, Alabama, Georgia. We know about their issues at the bottom of the
Yeah.
service delivery list of all the
Yes.
states, right? Louisiana. But I'm just concerned with our neighbors, like
Yes.
Pennsylvania is higher, Virginia is higher, of course, Washington, D.C. is much higher. So if we could just look at the neighboring states, Maryland, where we're in most competition for
Yes.
providers, and let me know. Look forward to your
It's a very
feedback.
good question. Now I'm curious, Senator, so I'm going to look into this.
Thank you so much.
Sure.
Deborah Sager. Thank you, Madam Chair.
Thank you. Senator Lamb?
Thank you, Madam Chair. Thank you for this presentation. Obviously, a lot of information packed in here. I want to start with the federal changes, right, with H.R. 1. And you had on slide 29 that there's like a $2.7 billion reduction that we're expecting to get from the federal government because of H.R. 1. Is any of that being offset in the governor's proposed budget, or is that just a straight reduction in loss?
So this is just an estimate, and so the governor's budget would offset this because the governor's budget invests in our systems to implement it. And so if we can mitigate coverage loss, about 1.4 billion of this 2.7 billion is if that entire 115,000 member group loses coverage. But if we can keep most eligible people covered, and we think the vast majority, 90%, are eligible, then that 2.7 billion could reduce to 1 billion or even much less. So the governor's budget, by investing in HR1 implementation, does work to address this high potential loss of funding.
Got it. So the 2.7 billion loss is actually accounting for reduction in beneficiaries too.
Exactly, yes.
I see. Okay.
And the reason why for this ACA group, they get a higher match rate, so they get 90-10. That's how Congress was able to get their high savings numbers, is if you make it harder for those individuals to enroll in coverage, it's greater savings for the federal government.
Right. Okay. When it comes to redeterminations then, so there were redeterminations that took place after COVID, like the COVID wind
Yes.
down, right? How many, I know there was a lot of effort that took place to try to reduce the loss of beneficiaries under the COVID wind down. What
Yes.
was our final number on where we landed with reduced number of Medicaid beneficiaries?
I believe you went for just over 1.7 million to 1.5 million, and Maryland did a very excellent job of maintaining those eligible and covered, some of the best in the country.
Okay, so we lost about 200,000 folks
Yeah.
that fell off because of COVID-related
And I think
wind down.
the majority of that 200,000 were no longer eligible. So they had employment insurance, they had marketplace, so it wasn't incorrect that some of those individuals lost.
Right, there wasn't
coverage.
anything we could do about those folks. It's not as though they just didn't make it through all the hoops. They actually didn't qualify.
Yes,
For
that's what we
most
believe,
of
the
those
majority of
folks.
those
Okay.
folks, yes.
Under HR1 now, we are going to be losing more folks. And I know you cited a few different numbers in here. What's the total number of beneficiaries you think we would lose because of
In a
HR1?
worst case scenario, 130,000 individuals. 15 of those 1,000 are people with immigrant statuses who wouldn't qualify. So those are definitely losing coverage. There's nothing really Medicaid can do for those individuals. The 115,000, that is sort of the estimation of people who wouldn't get through the additional red tape to keep their coverage.
Right, so those are they have to jump through a lot of hoops now, or additional hoops that they didn't have to before to retain their coverage. That's the effort that you all in the department are undertaking to try to reduce
Exactly.
that loss of folks. Okay. A question about the MCOs, because you also touched on some of these, that I think it's not my bill, but I think there are considerations of proposal to at least study the elimination of MCOs, right? And Connecticut went to this model, I guess, of having the state, I guess, administer the entire Medicaid program.
Bring it all back under fee for
bring
service,
it all
as
back
we say.
under the state.
Yeah, that's interesting.
The state obviously has been very efficient, and as you point out, the overhead is only 3 or 4% to be able to administer the Medicaid program. Have you had any conversations about eliminating the MCO side of things and bringing that all back in-house, or is that new?
So I will start by saying our managed care organizations have been terrific partners for the state of Maryland in terms of managing care, taking care of our members. So we have a great relationship with our managed care organizations. We have not had those conversations, Senator. I think that would be a fairly transformative look at our healthcare system, and then it would be a question of, is the goal better quality? Is the goal better care management? Is the goal cost savings? Again, we go through an extensive rate setting process with our managed care organizations to make sure that rates are sufficient. And it's not clear to me that eliminating MCOs we would still have those costs. We would just be managing it in-house. But the answer is no, we have not considered that.
Okay. Like I said, it's not my bill. I've just been hearing that there may be a bill that's being considered to at least study that. So, you should probably have that on your radar.
Yep.
I think most of the MCOs are working pretty well. There was an issue previously with Priority Partners, I think. Are they back on now, or is Priority Partners?
It was their NCQ health plan accreditation it was suspended last year, and the suspension was lifted in December.
Okay, so they are now, as of last month,
As of
able
last
to
month.
re-enroll people into Priority Partners.
The re-enrollment is starting February 1st because of operational steps we have to take to turn that enrollment back on. But yes, they are back on.
Okay. So I guess in that example, that's where one MCO was falling short, right? And so, I guess maybe that's why folks are looking at this Connecticut model where they've moved it all back in-house. But again, just something that you should probably look at. And so
I did want to just add, our MCOs are a key partner in HR1. They are sharing the cost of our communications campaign, and they do tremendous work to do outreach to our members too. But I appreciate that flag, and if you've ever talked to me, I love talking about other state Medicaid programs and trying to see where Maryland can do things differently or better. So I appreciate that.
Okay. So, obviously a lot going on with Maryland Medicaid. Commend you on, the outreach and continued communication. Obviously, we're hoping to minimize the number of beneficiaries lost. So, a lot of the implications of HR1, very, very concerning for those who are covered under Medicaid. We've done a great job as a state. This is another step backwards, unfortunately, along with the loss of the COVID dollars and potentially a significant loss of federal funding. So, do what you can to help keep as many people covered.
Thank you, Senator.
Thank you. Senator Mounts?
Thank you, Madam Chair. Just a quick question. I don't have a page 11, where it's talking about enrollment versus spending by eligibility category. One, and it's not specific to the information in the handout, but in talking at home with one of the expenses is reoccurring visits to the hospital for seniors. And do you have any information or breakdown of that spend? Can you get that particular in assessing your expenses of where those costs are for the seniors, particularly later on in life, where they're going to the hospital, multiple times, even within a month period. Do you have that? I know you probably don't have it with you now, but I'd be very interested to have a chance to take a look at that.
We can absolutely get that data for you, Senator. Yes, we have access to that. So yes, we'd like to get it for you. And then I can also, I'm sure there are ways that we try and prevent that clearly, because we don't want people rotating in and out of the ED if we can help it. So I can also look into just what policies are in place to support our seniors to make sure that that's minimal.
I appreciate that. Thank you.
Thank you. That ends the hearing. Thank you very much for your presentation. We're going to wait. It'll take a couple of minutes, and Tammy will switch over for the next briefing, and we have friends from B&T here with us. Just a couple minutes.